Welcome to another topic in the series Surgery for Undergraduates. Today's topic for discussion is cancer of the cecum or adenocarcinoma of the cecum. I shall discuss briefly a clinical case and its management, as cancer cecum is a very curable disease if detected early. The patient is a 68-year-old man with a 6-week history of lethargy and breathlessness on walking. He has loss of appetite and has lost 12 kg in weight over the previous 2 months. There is no history of fever or abdominal pain. He reports no rectal bleeding or change in bowel habit. His father died at the age of 58 from a colonic tumor. He is otherwise well and not on any regular medication. An esophagogastroduodenoscopy or OGDS has been previously requested by the GP and was done. It was normal. On examination, he was afebrile and his conjunctiva was pale and he looked cachectic. There is no jaundice or palpable lymphadenopathy. The chest is clear and the heart sounds are normal. Examination of the abdomen reveals a fullness in the right ilia fossa, but there was no tenderness or guarding. There is no associated hepatomegaly or ascites. Digital examination is normal. The picture on the left is a colonoscopic picture taken of the patient. Okay, it shows a large lesion here, a large polypoid lesion in the cecal area. Okay, it was inflamed, ulcerated with areas of necrosis. Biopsy of the lesion confirmed it to be a adenocarcinoma. This patient was then followed up with a CT scan, which similarly showed a large lesion or radio-opaque lesion in the area of the cecum. This is the ascending colon, and this is a cecum with a mass which is well encapsulated, suggesting it is within the wall of contained within the wall of the cecum. There were no significant lymph node enlargements in the region of the cecum and the aorta. So this was a diagnosed case of adenocarcinoma of the cecum. Now we'll proceed on with a discussion on cecum carcinoma, okay, or cecum cancer. The cecum is a pouch, okay, that is considered to be the first part of the large intestine, the beginning of the large intestine, which is attached to the appendix. The cecum lies on the right side in the vicinity of the appendix. The right-sided colonic cancers. Carcinoma of the cecum and carcinoma of the ascending colon and proximal transverse colon are grouped together as into the right-sided colonic cancer. This is because these three cancers have clinical presentation similar and common to one another. Therefore, they are usually classed together, and among them, carcinoma of the cecum is the most common. The patient with this right-sided carcinoma usually present with unexplained pain in the right ilia fossa, plus or minus general symptoms such as anemia, malaise, and weakness. This slide shows you the general layout anatomy of the large intestine. Okay, it consists of the cecum, ascending colon, and transverse colon, which are grouped together and called a right-sided colon. The descending colon, sigmoid colon, and the rectum are grouped together as the left-sided colon. Okay, the right-sided colon the presenting features are anemia, loss of weight, and mass. And in the left side, it is PR bleeding, change of bowel habit, and a left ilia fossa mass. This chart shows you the incidence of cancer in the various parts of the large intestine. Okay, the most highest incidence is in the rectum. It consists of 40% of the cases, followed by the sigmoid colon, about around 20 to 25% of the cases, and then thirdly is the cecum. Okay, about 20%. So of all the regions of the colon, rectum, sigmoid, and cecum lead the incidence of adenocarcinoma. Before we proceed further with the discussion, let's have a brief look at the anatomy and the structure of the blood supply of the artery of the large intestine. The right colon, which consists of the cecum, ascending colon, and transverse colon, are supplied by the superior mesenteric artery. Okay, the superior mesenteric artery, and this gives the ileocolic artery its first branch, followed by the right colic artery, which divides into a descending and ascending branch, and the middle colic artery, which gives you the right and the left branch. Okay, together they supply from the cecum right until the splenic flexure of the colon. On the left side, the descending colon, the sigmoid colon, and the rectum are supplied by the inferior mesenteric artery. Okay, the inferior mesenteric artery, and this supplies this left-sided colon through its left colic artery branch, which is the first branch of the left colic artery, which also gives you an ascending and descending branch and supplies the whole of the descending colon. Then through a number of sigmoid branches supplies the sigmoid colon. And lastly, the other branch, the superior rectal artery, supplies the upper and middle rectum. Okay, just it focuses on what the right side of the colon. This is the superior mesenteric artery, which gives you the ileocolic, the right colic, and middle colic arteries to supply the cecum right until the splenic flexure of the large intestine. Now we come to the etiology of colorectal cancers, in particular with reference to the right-sided cancers. Colorectal cancers originate from the columnar cells that line the colon and the rectum. And the carcinoma that is most commonly they give rise to is the adenocarcinoma, which constitutes almost 98% of the cases. Rarer types include lymphomas, carcinoid tumors, and sarcomas. The mechanism of cancer development is very interesting. It is called the adenoma-carcinoma sequence. Okay, where the carcinoma originates from an adenoma or polyp. The normal mucosa of the colon changes to colonic adenoma, okay, as is also known as the polyps, which then become invasive adenocarcinoma. These adenomas may be present for more than 10 years before becoming malignant. And progression to adenocarcinoma occurs in about 10% of adenomas. The second common conditions that are involved in the etiology are certain genetic mutations, okay, which predispose to colorectal cancer. Among them, the most common being the adenomatous polyposis coli, APC, which is due to a mutation of the APC gene, which results in the growth of polypoid or adenomatous tissue. The next is a hereditary non-polyposis colorectal cancer, HNPCC, which is also known as a Lynch syndrome. And mutation of this gene can result in this syndrome, which then may give rise to adenocarcinoma. Apart from the causes, what are the risk factors that predispose an individual to adenocarcinoma of the colon, especially the cecum? In 75% of the cases, the disease is sporadic. It develops in people with no specific risk factors. The remaining patients who are at risk with potential risk factors these are the factors, among which increasing age, family history, inflammatory bowel disease, low fiber diet, high meat intake, smoking, and alcohol. The clinical features in general: rectal bleeding, weight loss, abdominal pain, iron deficiency anemia. This is classically for the right-sided cancers. Classically, clinical features vary slightly depending on the location. Okay, and generally we can divide these locations into right-sided colon and left-sided colon cancers. In the right side, the predominant symptom is abdominal pain on the right side, right lower quadrant, occult bleeding with iron deficiency anemia, and mass in the right ileal fossa, which is often a late sign. On the left side, the left-sided colon cancers, the predominant presentation is rectal bleeding, change in bowel habit, tenesmus, and mass in the left ileal fossa, especially on PR examination. Coming back to our focus on the cecum and right-sided colon, the presentation include often they may be asymptomatic, okay, may present with just iron deficiency anemia and other vague symptoms such as weight loss and malaise, as in this case which we discussed earlier. Vague abdominal pain, which was not present in our patient, and fecal occult blood loss. Sometimes you may feel palpate or right ileal fossa mass, which can be mistaken for an appendicular mass. Okay, and this is usually a late sign of cecal mass or cecal cancer. It can also present as acute appendicitis, which is rare. Okay, and this is due to the tumor blocking of the entrance to the appendix. And distal ileal obstruction is also a rare presentation due to advanced disease causing obstruction of the ileocecal junction. Okay, now we come to the investigations for a patient with suspected colon cancer, especially the right-sided colon cancer. Okay, these include blood tests, iron deficiency anemia and CEA levels, fecal blood, fecal occult blood, and fecal immunochemistry tests to rule out bleeding, X-ray abdomen, plain X-ray abdomen, especially patients with mass, ultrasonogram, also especially for patients with mass, barium enema, which used to be an important examination, it will reveal an apple core sign. Colonoscopy and OGTS remains an important examination, especially colonoscopy, for the diagnosis of carcinoma of the colon. CT scan, especially contrast-enhanced CT scan, which is usually used for the staging of the disease. And nowadays, a lot of virtual colonoscopy is done. It's also known as CT colonography. Okay, this is becoming increasingly more widely used these days to confirm the presence of polyps and tumors in the colon. It is important that anemia of unknown cause with loss of weight always needs to be ruled out. Carcinoma right colon with the use of a colonoscopy and biopsy. The routine blood test which I mentioned, two types, full blood count or FBC, which may show you a microcytic anemia, it indicates iron deficiency. And the second one is the carcinoembryogenic antigen, okay, CEA. This should not be used as a diagnostic test due to its poor sensitivity and specificity. It is more used to monitor disease progression and should be conducted both pre and post operation and screening for recurrence. Okay, now I'll run through some of the investigations that I mentioned. Okay, this is a barium enema showing stenosis or apple core lesions of the carcinoma of the colon. Okay, so you can see here, this is a filling defect caused by the cecal tumor. Okay, and here this is a apple core sign here. Okay, also well seen. Again, this is an apple core sign due to the filling defect in the cecum due to the stenotic lesion of the mass within the wall of the cecum. Here again, you see here. Okay, this is the apple core sign, narrowing stenosis of the cecum. Here it is much clearly shown. Okay, there's a stenotic lesion in the ascending in the cecum. So this is the apple core sign, the core of the apple. Again here, another very clear. This is the apple core sign. Okay. This is a CT scan showing you a mass in the right iliac fossa region. This is the mass in the right iliac fossa. Okay, which is the cecum. There's an irregular mass with probably the bridge of the serosa of the bowel itself. Okay, this is the film which I showed you just now, the apple core lesion of the same patient. Here is another case of carcinoma of the cecum. Okay, this is the colonoscopy which shows you the lesion in the cecum, wall of the cecum, and this is the CT scan of the cecal mass. Okay, which seems to be large but well encapsulated, with no definite evidence of lymphadenitis or lymphadenopathy in the mesenteric region. Okay, these are colonoscopic pictures showing you a large mass in the cecum, suggestive of carcinoma of the cecum. Okay, areas of ulceration and necrosis. Here, another one, a large lesion in the wall of the cecum. And here, a huge polyploid growth in the cecum. These are all images of carcinoma of the cecum. Okay, this is the colonography which I was telling you, which is becoming increasingly more popular these days. It's also known as virtual colonoscopy. Okay, in this procedure, air is pumped into the rectum and the large intestine through a small tube placed in the anal canal. Okay, and then series of CT scan cuts are taken. Okay, this is especially good for locating polyps. This is a polyp. Okay, seen on virtual colonoscopy, and this is a real life colonoscopy. Okay, which shows you a cecal mass here. And here the distended bowel here. Okay, you see these are the polyps. This is a polyp. Okay, so this investigation is very good for identifying and locating polyps. Another one here. This is a polyp. Okay, once you identify the polyp, polypectomy can be done through the colonoscope to prevent the formation or progression of these polyps to cancer. Now we come to the staging of the disease. And the most commonly used is called Duke staging for colorectal cancer. Okay, A, B, and C are the original Duke staging. A means invasion, but not breaching the muscularis propria. Okay, so it is within the mucosa of the bowel wall. B breaches the muscularis propria, okay, but does not involve the lymph nodes. And C, it not only breaches the wall of the bowel, it also lymph nodes are also positive, the regional lymph nodes. Duke himself never described a stage D, but this is often used to indicate distant metastasis. This is the modified Duke stage, which is very commonly used these days to describe the stages of the disease. Okay, as I said, basically it's A, B, and C. Now we have subdivided to B to B1 and B2, and C to C1 and C2, depending on the depth of the tumor. Okay, C already, regardless of the depth of the tumor, the lymph nodes are involved, whereas B and B1 and B2, the lymph nodes are not involved, and the tumor penetrates to a different length, deeper length in B2 compared to B1. Okay, and A is tumor limited to the mucosa. So diseases A and B, stage A and B, are considered early carcinomas. Okay, whereas C and D are considered late carcinomas. All right, D is especially considered advanced cancer because of the distant metastasis. Okay, now come to the Tnm classification, which takes into consideration the tumor stage, that is T, the nodal stage, that is N, and M, the metastasis. Okay, again, T1, T2, T3, and T4, depending on the depth of invasion of the tumor into the wall of the bowel. N is whether the lymph nodes are involved, and again, the number of lymph nodes are involved is also taken into consideration. Okay, the cutoff point being 1 to 3, being N1, N2 is more than 4. Okay, this one shows you diagrammatically the Tnm classification. T1, okay, when it is involved only the mucosa. T2, when it breaches out of the mucosa, muscularis mucosa, it involves the muscle layer. And here it breaches the muscle layer completely. And here it breaches the serosa, T4. So these are the various depths of the tumor in the wall of the bowel to indicate different stages of the disease. Okay, now we come to treatment of carcinoma, right-sided colonic carcinomas. These are all the total or the complete list of treatment that are available for this tumor. And the most effective treatment, definitive, is surgery. Surgery is the most definitive treatment for early curative stages. The others can be used as adjuvant treatment. Okay, and if it is advanced, especially it's Duke's D, then you only can offer them curative treatment. Okay, the surgical treatment consists of surgical resection of the segment of the tumor of the bowel bearing the tumor. So there are two types for the right-sided colonic tumors. It's a right hemicolectomy and an extended right hemicolectomy. The right hemicolectomy is for cecal tumors and ascending colon tumors. Okay, and during this process, the ileocolic artery, which I showed you just now, the right colic artery, and the right branch of the middle colic artery are ligated together with the mesenteries. Okay, these are all branches of the superior mesenteric artery. In the extended right hemicolectomy, which is done for transverse colon tumors, in addition to the right colic and the ileocolic and the right colic, the whole of the middle colic vessels, including right and left branches, are divided and removed with their mesenteries. Okay, this is a diagrammatic presentation of a right hemicolectomy, which is done for cecums, lesions of the cecum and the right colon here. So you remove the whole cecum, ascending colon, right until the junction of the lateral and medial 1/3 of the transverse colon. Okay, here. And the arteries or vessels that you ligate are the ileocholic artery, the right cholic artery, and the medial right branch of the middle cholic artery. And then you use the terminal ileum to anastomose with the transverse colon. This is the ileocholic anastomosis. Okay, during the right hemicolectomy, the ileocholic, right cholic, and the right branch of the middle cholic vessels are divided and removed. Care must be taken to identify the right ureter, the ovarian and testicular vessels that may be related to the cecum. The extended right hemicolectomy, in addition to the ileocholic and right cholic arteries, the whole of the medial cholic artery is ligated and removed together with the mesentery. And this, the point of transaction is at the splenic flexure. So the whole right colon, cecum, ascending, and transverse colon are removed. Okay, resection of the portion of the distal ileum, cecum, ascending colon, and proximal to mid-transverse colon. Now we come to the prognosis of colorectal cancers. Okay, Duke's classification provides a good picture of the survival rate according to the stage. Stage A, limited to the wall, 90%. Okay. Stage B, extension to the pericholic fat. No lymph nodes are involved. That means the wall is involved and no nodes involved. So 70%. Okay. In C, whereas immaterial of the amount of wall that is involved, there are lymph node metastases. So the prognosis drops to 30%. And with D, the metastasis, distant metastasis, is only 10%. So, as I said, these two are considered early cancers. Okay, this is terminal cancer and this is late cancer. Okay, so these are the three categories according to Duke's classification. So as you can see here, A and B prognosis is very good, 5-year survival rate, whereas C and D, the prognosis becomes more dismal or unfavorable. Okay, now we come to the carcinoma of the summary of what we have been discussing on this few minutes. Right colon carcinoma. Okay, summary, the clinical features, symptoms and signs, anemia and loss of weight. Okay, so this is a very important factor that you must consider in patients. Compared to the left colon, is more of PR bleeding and change of bowel habit. Investigations, colonoscopy and CT scan. Okay, remains the two important investigations for right-sided carcinomas. Staging is usually we use modified Duke's classification. And for treatment, right hemicolectomy with ileocholic anastomosis, which I told you just now. Right hemicolectomy with ileocholic anastomosis. And this is based on the arterial supply, okay, which I highlighted to you earlier. Which segment you remove depends on the arterial supply as well. And as far as prognosis is concerned, good prognosis with Dukes A and B, poor prognosis with Dukes C and D. So what are the key points in this patient? The key points in this patient that we have studied is that symptoms, the key symptoms of colorectal cancer are the change of bowel habits and rectal bleeding. Cecal and right-sided colon cancers may have vague symptoms of anemia and unexplained weight loss. So this is very, very important. Age, family history, and diet are important risk factors to consider in patients with cecal carcinoma. The gold standard diagnosis is made via colonoscopy with biopsy. CA is only useful in monitoring treatment efficacy and disease recurrence after treatment. It is not a diagnostic test. Surgical resection of right hemichorectomy remains the only definitive cure for right-sided colonic cancers, especially carcinoma of the cecum. And chemotherapy, immunotherapy serve as adjuvant therapy in some cases. In short, unexplained anemia with loss of weight, especially in an elderly female patient, you must always insist on a colonoscope and biopsy for this patient, because early detection, as you have seen, gives very good prognosis compared to late diagnosis. We have come to the end of this session on carcinoma of the cecum. Carcinoma of the cecum is a curable disease as long as you are detected early in Dukes A and B. So it is utmost important that you have a high degree of suspicion, especially in patients, elderly female patients who are coming with unexplained anemia and loss of weight. A colonoscopy is a must for these patients. The earlier you do, the better it is for the long-term survival of the patient. So thank you for joining me, and I hope to see you again in another of these sessions in the near future. Meanwhile, you may visit the YouTube channels as indicated in this link which is given in this page. Thank you.